Every shift, there's a moment when the noise fades. The patient's gone, the paperwork's done, and it's just you, the road, and everything you're still thinking about. This is when the real conversations start. The ones about calls that didn't sit right. The things we do because that's how we were taught. And the quiet question nobody says out loud. Are we actually doing the best we can? EMS is built on tradition, but medicine keeps moving, whether we move with it or not. This show is about closing that gap between old habits and new evidence, between doing things right and doing things because we always have. No hype, no hero talk, just honest conversations about pre-hospital medicine, the same ones we have in the truck, in the station, and on the drive back when the sirens are off. This is the Tone Drop Podcast. What's up, everybody? Welcome back to the Tone Drop Podcast. This is episode number 2, titled EMS Myths That Refuse to Die and Why They're Still Hurting Patients. So let me just be clear up front. This episode is probably going to make some people uncomfortable. And honestly, that's fine, because if it doesn't, I didn't do my job. Because there are things that we still do in EMS, not because they work, not because the evidence supports them, but because nobody wants to be the person who stops doing them. And before anybody gets defensive, let me be clear, this episode is not old school versus new school. That's next episode. This is habit versus medicine. Because good medicine isn't old school or new school, it's current. And some EMS myths just refuse to die. So today, I want to talk about a few of them. Why they started, why they stuck around, and why hanging on to them in 2025 actually does more harm than good. So let's start with the big one. The sacred cow of EMS, if you will. Backboards. And here's the truth. If backboards actually protected spines, trauma centers wouldn't treat them like infectious waste the second we roll through the door. You've seen it, I've seen it. You bring a patient in on a board. The first thing they do is cut the straps, slide the patient off, and toss the board into the corner like it's personally offended them somehow. And yet, for some reason, EMS still treats longboard transport like it's the gold standard. But here's the reality of that. Backboards were designed for extrication, not transport. Short-term movement. Getting someone out of a vehicle or off the ground safely, not laying someone flat for 20 to 40 minutes while we bounce down the road. We also know what backboards actually do. Increased pain, pressure ulcers, respiratory compromise, especially on elderly patients, obese patients, patients with kyphosis, or patients who generally don't have a spine that likes to lay flat. And the worst part is backboards create a false sense of security. Some providers think, oh, well, they're immobilized, and suddenly assessments get sloppy. Neurochecks get rushed. We stop reassessing because the patient is secured. That's dangerous. So why do backboards persist? Fear, lawsuits, what-if medicine. People are more afraid of being blamed for not boarding someone than they are of the very real harm that backboards cause. But doing something out of fear isn't good medicine. Here's another part that people don't like to talk about. Backboards also change how patients behave. Because once someone is strapped down, they stop moving. Not because they're stable, but because they're uncomfortable or they're scared. That can mask deterioration. A patient who would otherwise shift, guard, or suddenly complain goes quiet. And quiet patients don't always mean stable patients. There's also a training issue because a lot of newer providers are still being taught backboards as a reflex, not a decision. No mechanism discussion, no risk stratification, just trauma equals board. That's not critical thinking, that's muscle memory. And when EMS leans too hard on muscle memory, we stop adapting to the patient in front of us. We treat categories instead of humans. So backboards didn't survive because they're effective. They survived because they're familiar. All right, let's move on to oxygen, the most overused drug in EMS by far. Oxygen is not benign, it's a drug, and EMS is one of the last places still pretending that dosage does not matter. We still see non-rebreathers slapped on patients with SATs of 98 or 99% just in case. And I get why. Oxygen feels like action. It looks good. Families like it. New EMTs love it. It feels like we're doing something, even when we can't do anything meaningful. But hyperoxia is a real thing. We know this. Stroke patients, MI patients, COPD patients, we've had the data for years. Yet the habit persists. Why? Because titrating oxygen requires thought and explanation. It's easier to blast someone with O2 than it is to explain to a family why you're not. But lazy medicine dressed up as caution is still lazy medicine. If we wouldn't give a medication without checking a dose, we shouldn't be doing it with oxygen either. Another uncomfortable truth is that oxygen overuse often replaces assessment. Instead of asking, why is the patient short of breath, we reach for oxygen like it's a solution instead of a temporary support. And once the mask is on, sometimes the thinking stops. There also is a cultural problem with EMS because we've been trained to believe that withholding oxygen looks negligent, even when it's clinically appropriate. But that fear pushes providers toward overtreatment, not better care. And overtreatment isn't harmless. It's just quieter than undertreatment. Good medicine isn't about doing the most. It's about doing what's indicated. Oxygen should be treated with the same respect as any other medication that we give. All right, number 3, and this one's a little bit sneaky, but it's the myth of immobilize first, assess later. If your first move is strapping plastic to a patient before checking airway and bleeding, you're practicing habit, not medicine. Think about how many scenes you've been on where the collar goes on before you even fully understand what happened. We get so locked into the routine, collar, board, straps, that we forget what actually kills patients early. Airway issues, breathing problems, hemorrhage, the ABCs. We all learned that in EMT school. Immobilization looks controlled. It looks organized. It feels like we're doing trauma. But good trauma care isn't about how fast you can apply equipment. It's about prioritization. Somewhere along the way, immobilization became the task instead of patient care. And when that happens, people stop thinking. This myth survives because immobilization gives providers a sense of control. Scenes are chaotic. Trauma is stressful. Immobilization feels like structure in the middle of uncertainty. But structure doesn't equal priority. The danger is that we start managing our own anxiety instead of the patient's physiology. Airways don't care how neat your scene looks. Bleeding doesn't care if the collar is perfectly sized. Time-sensitive problems don't wait for us to finish our checklist. Immobilization should be a decision, not a reflex. And decisions require thinking, not rushing. Okay, so number 4, and this one is probably my biggest pet peeve in EMS. It drives me insane. The idea that pain control masks symptoms. Look, withholding pain meds to get a better exam says more about the provider's insecurity and uncertainty than it does patient safety. Uncontrolled pain does not improve exams, it worsens them. It spikes heart rate, raises blood pressure, and increases stress hormones. And yet we act like suffering is diagnostic. We'll let trauma patients writhe in pain because we're afraid it'll somehow hide an injury. Meanwhile, hospitals are managing pain early and often. Let's be honest about why this persists. Fear of being wrong, fear of chart review, fear of judgment from other providers. But patient comfort isn't optional care, and pain management isn't a reward, it's treatment. Here's what really happens when we withhold pain control: we shift suffering from the injury to the patient. Pain becomes something they have to endure to earn care, and that mindset has no place in medicine. There's also an empathy gap because providers who are burned out or emotionally numb sometimes underestimate pain, not because they're cruel, but because they've normalized trauma due to their jobs. But normalization does not make suffering for the patient less real. Pain management does not compromise assessment. It improves cooperation, improves trust, and often improves outcomes. A patient who feels heard and treated is easier to assess than one who feels ignored. All right, number 5. This one's a little bit uncomfortable for some, but it's the myth that protocols equal good medicine. Listen, protocols are safety rails, not autopilot, and anyone using them that way probably should not be the one driving patient care. Protocols are important, don't get me wrong. They protect patients, they protect providers, but they don't replace thinking. Somewhere along the way, compliance became more important than outcomes. Did you follow protocol replaced did the patient benefit? Deviation shouldn't cause panic, it should prompt discussion. If your medicine can't be explained without pointing to a protocol, that's a problem. Because protocols were never meant to be shields, they were meant to be tools. But somewhere along the line, EMS started using protocols to avoid accountability instead of support decision making. If something goes wrong, I followed protocol became more important than I did what was right for the patient. That mindset creates providers who are technically compliant but clinically passive, and passive medicine is dangerous medicine. The best providers know their protocols and know when the patient in front of them doesn't fit neatly inside of one. Clinical thinking isn't deviation, it's professionalism. We always call these type of people cookbook medics. Basically, somebody who reads the protocol book like it's a recipe and they follow it exactly. They won't deviate, they won't change. They try and squeeze every patient they have into one particular protocol, and that just does not work. It stops all critical thinking. So here's the hard truth: EMS culture lags behind evidence, not because people are dumb, but because habits are comfortable. And changing habits means admitting we were wrong before. That's hard, especially in a profession built on confidence. But doing something because we've always done it isn't a defense, it's an excuse. So here's the challenge: ask why before you act. Learn the evidence behind your habits. Be able to explain your care, not just defend it, because good medicine evolves. And at the end of the day, good medicine isn't old school or new school, it's current. Some myths deserve to finally die.